Welcome to the Late Life Depression Conference Call. My name is Jenny and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to John Glover. You may begin.
Thanks. Hello, everyone. Welcome to today's presentation. My name is John Glover, and I'm a project specialist with the Lake Superior Quality Innovation Network. The Lake Superior Quinn is comprised of 3 organizations: Impro in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality and improvement. We know that you and your organizations are working hard to improve healthcare and quality outcomes, so we hope that what you learned today will help you be more successful in those efforts. Today's session is being recorded and will be available in about 2 weeks at our LSQIN website under the Events tab. Before we get started, I need to cover some required disclosures related to continuing education. Because Metastar is providing continuing education credit for this presentation, we need to inform you that no commercial support has been received for this learning activity. The speakers and planners have no conflicts of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. You will receive the link to the evaluation at the conclusion of today's webinar. Social workers who would like CE credits must complete the online evaluation and a post-test included in the evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. All right, with that out of the way, today we have the pleasure of talking with Dr. Art Walasek from the University of Wisconsin Department of Psychiatry. Dr. Walasek is a board-certified geriatric psychiatrist and professor of psychiatry at the University of Wisconsin School of Medicine and Public Health. He received his medical degree from Northwestern University Medical School, completed psychiatry training at the University of Washington in Seattle, and completed a fellowship in geriatric psychiatry at Northwestern Memorial Hospital in Chicago. He is also Vice Chair for Education and Faculty Development and Director of Psychiatry Residency Training at the University of Wisconsin Department of Psychiatry. He works with the Wisconsin Alzheimer's Disease Research Center, where he is co-leader of the Outreach, Recruitment, and Education Corps. His mission is to improve the care of people with Alzheimer's disease through education of medical students, residents, and clinicians in practice. As a member of the Wisconsin Geriatric Psychiatry Initiative, Dr. Walasek speaks extensively on geriatric topics in various medical and non-medical settings across our state. He has co-authored articles and book chapters on late life emotional and behavioral problems, anxiety disorders in long-term care, late life depression, and ethical issues in late life. His clinical practice involves caring primarily for older adults with depressive disorders, anxiety disorders, and dementia, and their families. And if this isn't impressive enough, if you ever have the pleasure to meet him or work with him, you will find that he is a warm and caring professional of the very highest caliber. Art, thanks so much for being with us here today.
Certainly, John. Thank you very much for that incredibly warm and gracious introduction. Talking about working with older adults, and in particular late life depression, is near and dear to my heart. So I'm very happy to be part of this, and thank you for taking up this important topic.
You bet. Let's start off with identifying the objectives that we have for our talk today. We want to start with identifying the types of depression that are common in older adults. We want to examine the relationship between depression and other medical conditions, as well as explain the types of screening tools and assessments that can help identify depression in older adults. And finally, we want to help recognize the various treatment options that might be most effective for the older adult population. So, in starting off, Dr. Walasek, could you tell us a little bit about the different types of depression found in late life?
Absolutely. Thank you. So, we think about depression in older adults in a lot of ways quite similar to what we see in younger adults, but also some pretty critical differences. So, in terms of similarities, like in younger adults, we use the DSM and think about diagnosis in terms of people meeting criteria for particular disorders. So specifically, major depressive disorder applies just the same in older adults as it does in younger adults. And so that includes 5 of 9 depression symptoms, and at least one of those has got to be either low mood or lack of interest or enjoyment in things. And then the other typical depression symptoms that we would see in younger adults, like changes in sleep, energy, appetite, feelings of guilt, worthlessness, and suicidal ideation. And we'll come back and we'll talk about suicide later on, because that's a particularly critical topic across the board, but especially in working with older adults. Those symptoms need to have been present for at least a couple of weeks. In reality, often people go months or years before they seek or get appropriate treatment for depression. And then there's got to be some associated distress or impairment. So that's major depression for a 25-year-old, for an 85-year-old. The criteria are the same. The symptoms themselves can look a little bit different, and we tend to see in older adults a little more somatization, meaning people kind of focusing a little more on some of the physical side of things. Some older adults with chronic headaches or chronic nausea, for example, there might be a depression component underneath all that. We tend to see more cognitive issues in older adults with depression. So there's a term or a concept called pseudo-dementia, where people look like they have dementia because they have so much trouble with their memory or their attention span, but in reality, they don't. It's their underlying depression that's causing it. And we could actually see that at any age group. A young person with depression can have problems with their focus and concentration and decision-making. And in older adults, that can look so severe that it appears the person has dementia. So those are some of the differences in major depression. Major depression is probably actually a little less common in older adults than in younger adults. But there's another form of depression that seems to be more common in older adults, and that's called minor depression. So recall, major depression, you've got to have at least 5 of the symptoms that I mentioned earlier. In minor depression, it's 3 or 4 of the symptoms. So it's kind of a less severe form of the depression. And there's still functional impairment or distress, but less so than what we see with major depression, and more than what we would expect for normal aging, which is something we'll talk about in just a few minutes. So minor depression is an important construct because it's a signal that the person's not doing well emotionally, and it's also a marker that they may go on to develop more severe depression, specifically major depression. The final type of depression I want to talk about in this section is vascular depression. So that's something we don't see all that often in younger adults, but is not uncommon form of depression in older adults. Here's the idea. As you get older, your brain is more likely to have problems with blood flow and to get little strokes. And these are actually not uncommon. There are lots of parts of the brain that just don't have great blood supplies, really weren't designed to be around 75 or 85 or 90 years. And so when you've got a part of the brain that's not getting adequate blood flow, you can have a stroke. It can be a huge, devastating stroke, or it could be a very tiny one that you kind of barely notice the impact of, if at all. Older adults who have more strokes are more likely to have depression than older adults who don't have any strokes or have fewer strokes. And the way to think about this is that our brain does lots of amazing things, and one of the amazing things it does is it holds interest in things. It helps us go and do things that we want to do. We find enjoyment and pleasure in things. And when those brain circuits that are involved in that aren't working properly anymore, then we can develop depression or something that looks a lot like depression. And so a stroke, especially in a part of the brain that has to do with this circuitry that is involved in what we call emotion regulation, If you have a stroke in that area, that could end up in someone having depression. Or if you have a bunch of little strokes in that area, same thing. So that's vascular depression. It's depression in the context of someone having had strokes and thought to be due to those strokes. And it looks a little different than regular major depression. The predominant feature here tends to be more apathy, lack of interest, lack of enjoyment. The person themselves may not necessarily say that they're depressed. In fact, they might just flat out deny that they feel depressed. They're just bored or disinterested. Sometimes families are much more upset about what's going on than the person themselves, because they wonder, well, why is Dad not so interested in activities like he used to be? And he quit going to his regular coffee group or bowling or whatever it might be. And Dad himself is not all that bothered by it. It's the family around him who's really worried about him. So that might be a picture of vascular depression. Vascular depression is a little harder to treat than regular depression. It doesn't seem to respond quite as well to antidepressant treatments and psychotherapy, the usual treatments. So that distinguishes it a bit as well. And it also it kind of helps hit home, well, why do we care about things like high blood pressure and high cholesterol and getting people to quit smoking and, lose weight and so on? It's because we're trying to promote brain health as much as possible. And in turn, the better control we have over things like cholesterol, diabetes, blood pressure, weight, the less likely someone will go on to develop vascular depression. One final note on vascular depression is that it could be a first step on the direction to dementia. So someone who's never been depressed before in their life and then now in their 60s or 70s or 80s has their first depression, that's worrisome. That's concerning that they may go on to develop either Alzheimer's disease or vascular dementia or another form of dementia. So that makes identification of this important too.
It's really great. But, depression in late life really isn't the norm, right? I mean, you mentioned that before.
Absolutely. I mean, I think what's remarkable, so I like to reflect on, what is my life going to look like at 75 or 80? I'll probably be retired then. My kids will be away. The grandkids will be living in a different city. I'll probably have some health problems. Like, wouldn't I be depressed in that context? But the fact of the matter is that most older adults don't develop major depression or minor depression for that matter. And I think, I'm not exactly sure why that is. I mean, I think some of it is that, if you've made it to 80, you've probably seen a bunch of stuff and dealt with a lot. And so resiliency has become more possible in that context. We really, find that most older adults who are not in clinical settings continue to have good capacity for relationships. They're still productive. They're looking for ways to give back, to take care of grandchildren, to volunteer in the community, to be a reading tutor, a math, whatever. Most folks, I sometimes forget this because I see the depressed ones. I don't see the non-depressed ones. They're out of the community living their life. Most older adults don't get depressed. And in fact, it's a bit of an ageist stereotype. I think there's some, stigma around aging. We're a very I can stand on the pulpit for like 3 seconds. It's a very youth-obsessed culture, and so aging sort of brings with it, well, of course you're going to get depressed. You're old. What value do you have, et cetera. And that's a horrible stigma and stereotype about aging. The reality is most people will never end up in a nursing home. Most people will not get depression, et cetera, et cetera. So so age, and so that's the goal, is if someone does get depressed, okay, that's not their fault. They've got an illness. Let's get that figured out so that we can get them back to resilient and capable of having relationships, productivity, and creativity.
Yeah, absolutely. You mentioned earlier some of the medical conditions that are comorbid with depression. Would you mind talking a little bit about that?
Yeah, absolutely. And I think that's another area where things are fairly different working with older adults than younger adults. I mean, certainly younger adults get illness, they get traumatic brain injuries and cancer and accidents and various things. But it's certainly much more the norm, more what we'd expect to see in older adults. And there are a number of medical conditions that then are linked with having a higher rate of depression. So I'll just run through some examples here. So heart disease is a classic one. So, and by heart disease, what I mean is specifically people having blockage of arteries so they can get a heart attack as a result of that and then lose some heart function. So folks who have had a heart attack are at higher risk of developing depression afterward than folks who have not had a heart attack. Interestingly, it goes the other way too. So depressed people are more likely to get a heart attack than non-depressed people. So there's kind of a two-way relationship there. And some of that could be behavioral. Depressed folks may not exercise as much, might not take as good care of themselves physically or follow regimens that they need to maintain heart health. But there's also a mind-body link there, too, that people with depression just may have less good heart health to begin with. So kind of two-way relationship there between heart disease and depression. Cancer, there are certain cancers that are kind of notorious for being associated with depression. Pancreatic cancer is one of them. Historically, that was a pretty awful cancer with low survival. Survival's gotten a lot better over the last decade or so. But the pancreas cranks out all kinds of interesting hormones. And it's thought that with pancreatic cancer that you may actually end up with a hormonal disturbance that leads to a higher risk of developing depression. Same with a lot of the blood cancers like leukemia. Those tend to have higher rates of cancer. And some of the leukemias are not uncommon as you get older. Diabetes, mostly through the kind of connection with heart disease and stroke, can be associated with depression. And then depressed folks may not do as good of a job taking care of their diabetes, and so then you kind of get into a worsening cycle. And then there's dementia. So dementia is any condition where you lose cognitive functioning like memory, attention, decision-making, impulse control, planning, problem-solving, and you lose some associated functioning with that, like being able to drive or manage your finances or go grocery shopping or take your medications right or whatever. So the most common cause of dementia is Alzheimer's disease, and about half of people with Alzheimer's disease will have some depression along the way. Stroke is another cause of dementia, and we've already talked about that, and it's linked to depression. Parkinson's is another common cause of dementia. Some folks may have heard of the construct of Lewy body disease or Lewy body dementia. That's kind of in the same ballpark as Parkinson's disease is. And both Parkinson's and Lewy body dementia carry with them pretty significant risks of depression. Again, probably around half of folks with Lewy body diseases or Parkinson's will eventually develop some depression. And the way to think about that is, these are awful diagnoses, and so you could view it as an understandable psychological reaction. Oh my goodness, I've been diagnosed with depression, I'm going to give up, with dementia, I should give up, I'm hopeless, etc. But also, going back to the brain circuitry idea, Parkinson's and Alzheimer's both have dramatic impacts on how our brain works. So just in the case of Alzheimer's disease, there's a little organ, or two organs actually, deep within the brain called the hippocampi, and they're involved in memory. So if you retain anything from this presentation today, you can thank your hippocampi. You've been paying attention. Your hippocampi are encoding this information. And if you forget it, you can also blame your hippocampus, although it's possible other things. If you weren't paying attention, you could blame your frontal lobes. But you need your hippocampi to form new memories. So Alzheimer's disease is a disease where you can't form new memories, and the hippocampus is to blame, at least at first. The hippocampus also plays a really, really important role in emotion regulation. So let's say in the middle of this talk, a bear walked into your office you would remember this talk extremely well, because that's the hippocampus's job, is to say, whoa, something really interesting and exciting and potentially lethal just happened in the environment. I need to pay attention. So the hippocampus binds emotion with memory, and it's an important part of what's called the limbic system, part of the brain that has to do with emotions. And so in Alzheimer's disease, you got a problem with the hippocampus. That leads to memory problems, but it can also lead to emotion problems, because you're actually hitting that part of your brain that has to do with emotion regulation. The other part of what's going on in the dementia-depression relationship is that, as the dementia progresses, people have less ability to care for themselves, may need to depend more on others, and that can be a challenge in terms of your sense of self-efficacy, of control over your life, of feeling like you can do things on your own. That shift over to I need help with whatever task can be very challenging for folks, and can lead to some depression as well. So, really complicated. Again, sort of a two-way relationship between depression and dementia. As I mentioned earlier, depression can look so bad in older adults that it seems like you have a dementia or pseudo-dementia, and late onset depression seems to be a predictor of later developing dementia as well. There are a bunch of other possibilities. John, I don't know how much you want me to talk about other stuff. I mean, there's like pain, there's vision loss, there's other stuff we could talk about as well.
Sure. It sounds, though, that it's really hard to think about a lot of these chronic diseases without considering the potential impact of depression, right?
Absolutely. Yeah, and depression affects motivation, it affects interest. And so being able to follow up on these medical problems, which are often very complex, involving lots of doctor's visits and physical therapy and labs and going to the pharmacy and all that, that's difficult if you're depressed.
Yeah, so in order to sort of identify people who might be struggling with depression issues, could you talk a little bit about screening options and assessment to identify these folks?
Yeah, absolutely. There are a lot of options out there. Some of these screens have been specifically designed for older adults, and some are just really borrowed from the general population and have been used and validated in older adults. So there's been a big push to do more screening of older adults. It's now part of the Medicare annual wellness check to screen for depression. And so the simplest place to start is to do a PHQ-2. PHQ-2 are just the two core features of depression: feeling low, down, or depressed, or losing interest or enjoyment in activities. And answering yes to either one of those questions is a positive screen. It doesn't mean that you have major depression, but it means that further investigation is required. And usually what will happen is then you'll just go on to the PHQ-9. So you already asked 2 of the 9 questions. There are just 7 more to go. And those are the ones that have to do with the other DSM criteria for depression, like sleep and energy and appetite and suicidal ideation and so on. So those have, I think, very quickly become the standard of care and are well established, especially in primary care settings, and they are validated in folks over 65. One of the tricky parts about diagnosing depression in older adults is that a lot of the physical symptoms of depression look like other things. So fatigue, for example. So fatigue is a core finding in depression, but it's also a core finding in congestive heart failure, in COPD, in sleep apnea, in Parkinson's disease, in stroke, actually really in many neurologic diseases like MS and others. Fatigue is very common. Cancer fatigue is common. Anemia, hypothyroidism, where the thyroid isn't functioning right, and medication side effects, and alcohol, and the list goes on and on. So So in other words, fatigue is a really non-specific finding. Sleep problems are fairly non-specific, and appetite changes can be pretty non-specific too. So the Geriatric Depression Scale, or GDS, was developed to really specifically look at what does depression look like in older adults. It de-emphasizes the physical symptoms of depression, and it emphasizes more the psychological side, the guilt, helplessness, hopelessness, worthlessness, suicidal ideation, those kinds of things. So the GDS, the most commonly used form, is the short version, which is 15 yes/no items. It's available for free. If you just Google it, you'll find it. And it can be a self-report. People can just complete it like in a doctor's waiting room or online or whatever. And there are established cutoffs for depression. And you can use it to track people over time to see how they're responding to treatment. And that's true of the PHQ-9 as well. So in my own clinic, I use the GDS because I see just older adults. If you had a mixed clinic, you could use the PHQ-9. John, do you want me to move on to the STAR method, or should I say anything else about it?
Sure. No, one of the things I remember you talking about too with the Geriatric Depression Scale is the simplistic responses as opposed to the PHQ-9, right?
It's all yes/no. It's really easy. The PHQ-9 is some of the time, all the time, most of the time kind of thing. The GDS is really simple. It's just yes/no. Have these things been present recently or not? So it's nice and easy.
And it helps the older adult to answer the questions and valid. Yeah.
I think so.
Yeah. So maybe we could talk a little bit about the STAR method, and I'll put that slide up for people so they can see what we're talking about there.
So one of the challenges in this setting is that things get complex real fast. I mean, just in 27 minutes, we've probably mentioned like 12 different medical diagnoses, a bunch of different forms of depression, all the different ways depression's different from younger folks, some of the psychological aspects of aging. So it can get overwhelming. So the STAR method is a way of kind of helping people disentangle some of this. It was developed by Dr. Tim Howell, who's a geriatric psychiatrist still practicing here in Wisconsin. He developed this probably close to 15 years ago or so as a way of helping people of all sorts, from medical students to doctors to social workers to psychologists to families themselves to case management teams, kind of grapple with the complexity of what's going on and be able to pull some of these issues apart, and also recognize how they interact with each other, and then finally help with turning that into a treatment plan. So what the STAR method says is, okay, for any older adult who's presenting with some problem, and it could actually be anything. It doesn't have to be psychiatric. It could be falls. It could be urinary incontinence. It could be failure to thrive, or depression in this case. What are the different possible contributing factors, and how are those contributing factors interacting with each other? So I'll just go around the horn of the STAR here. So medication issues, lots of medications have been implicated in contributing to depression. Steroids, opioids, anti-anxiety medications like benzodiazepines, and kind of lumping into there too, it's not a medication, but is a commonly used substance, very commonly used substance, alcohol. Alcohol has clear depressant effects. So that's one point of the STAR. Medical issues, we've already talked about that quite a bit. Premorbid psychiatric psychiatric issues, like already having had depression in the past or anxiety disorders in the past. Personality issues, so as people age, they don't lose their personalities. In fact, in some cases, pre-existing personality components just kind of get more emphasized. And so, let's just say you're a person who likes to have everything completely in control and arranged the way you want it, and things work like clockwork. Aging's going to be rough. Things don't work like clockwork. You're up at night peeing, and your joint isn't working properly, and something that would have taken you 10 minutes to do now takes you an hour to do, and now there's some chronic pain, et cetera, et cetera. So thinking about the person's personality type and how that might be exacerbating things or potentially helping things. If you're super duper organized and meticulous, well, that's great because as you age, there are going to be millions of forms to fill out and decisions to make and so on, and so that can be helpful. And then psychosocial issues like loneliness and isolation and loss of family members and so on. So STAR method helps you disentangle all those things and also helps you get to think about treatment. So if I'm depressed, one option might be let's go ahead and start an antidepressant. But another option might be, well, let's optimize the treatment of the underlying medical conditions like sleep apnea or chronic pain or vision loss or whatever. Let's address the psychosocial issues like the lack of contacts and support and the boredom and loneliness and isolation. Maybe psychotherapy is going to be in order. Let's look at that medication list and really clean it up and see if there's something there that's contributing. And certainly, if I'm drinking too much, I should reduce or eliminate my drinking if I really want to adequately treat my depression. So that's one of the lovely things about the STAR. It's not just about helping understanding what's going on, but also giving you some pathways for how you can intervene and help a person with depression.
Well, that's a great lead-in to our next topic, which is treatment. And I think it would be really helpful for you to talk to us a little bit about treatment and how it differs in older adults.
Absolutely. So, the good news here is that in general, late-life depression responds just as well to conventional treatments for depression as in younger adults. So the gold standard for treating anybody of any age with depression would be some combination of medications and psychotherapy. That's the gold standard. And the two together, so either one or the other or both. And the two together are more effective than either one alone most of the time. So medications. So the good news on medications is they're about as effective in older adults as they are in younger adults, and that's specifically antidepressant medications. So, the biggies are the SSRIs, the selective serotonin reuptake inhibitors. So those are drugs like sertraline or Zoloft, citalopram or Celexa, escitalopram or Lexapro. I named those three specifically because those are the three antidepressants least likely to interact with other medications, which is a big issue with older adults. So older adults may already be on a bunch of medications, and so we have to weigh carefully, does it make sense to add yet another medication, and how is this medication going to play with the other medications? So some are better than others in that regard. There are other antidepressant classes. There are the SNRIs or serotonin norepinephrine reuptake inhibitors. So those are drugs like venlafaxine or Effexor, duloxetine or Cymbalta. Those work quite well in older adults as well. So just in general, the meds in terms of efficacy are about the same in older adults as in younger adults. Side effects is where it's different. And so older adults are more prone to side effects, including some things we don't see so much in younger adults, like pretty much any psychotropic medication that an older adult takes is going to increase their risk of falls. So that's just kind of a given. Now, interestingly, depression also increases the risk of falling down. So you have to balance that. The hope is, okay, I'm going to start this person on sertraline. That's going to increase the risk of falls, but they're also quite depressed and they're not getting out of bed much, and that's going to increase the risk of falls. So my hope is that I'll get them more active, walking again, going to exercise, and that positive effect is going to be greater than the negative effect of risk of falling with medication. So that's one example. But just in general, older adults are less likely to tolerate psychotropic medications than younger adults. So that influences our treatment strategy. It means that A, we have to think carefully, do we really want to start a medication? B, when we do, we start low, so doses are half the usual adult starting doses, maybe even a quarter, and then we go slow. We titrate, we increase the dose of the medication slowly. That means it's going to take longer to get better, unfortunately, but it also means that it'll be more tolerable and less likely to cause significant side effects. So medications, definitely a potential treatment of depression. The other core treatment is psychotherapy. And the great news is that psychotherapy works just as well for older adults as for younger adults. It's a myth that psychotherapy doesn't work for older adults. There's sort of this old teaching that, once you hit a certain age, everything's hardwired, nothing's going to change. That's simply not true. I mean, my own clinical experience is that it might be a little harder, but you can still shape people's behavior and the way they think about things. Our brains are remarkably plastic organs that do continue to change. In fact, again, if you've learned anything from this hour, it's because your brain has actually changed. You've got some new connections among neurons storing that information from this presentation. So similarly, anytime anyone learns anything new, they're storing new information. And psychotherapy, one way to think about it is you're learning new information, learning new things about yourself, about the world. You're challenging some faulty thinking about the world and trying out new behaviors and emotion regulation skills and so on. So psychotherapy works. Light is interesting. So this is a consortium of providers in Michigan, Wisconsin, and Minnesota. And one thing we have in common is that we're all pretty far north. So seasonal depression is directly linked to how far you are away from the equator. And so we are in an area that has a lot of seasonal depression. And on top of that, older adults just don't get as much, they don't get out as much, they don't see as much sunshine. And sitting in front of a bright window in your apartment does not qualify. It's not bright. It's not bright enough to really get that light exposure. Conversely, when you go outside, it doesn't have to be a sunny day. It can be a gloomy day. It's still way more light than inside. And so we prescribe either get outside and get some light, or if that's difficult to do in the winter, a light box. So a bright light that's emitting light at a very high brightness, 10,000 lux, that people sit in front of for 20 to 30 minutes each morning. And what's interesting for older adults is that it doesn't just work for seasonal depression, but for non-seasonal depression. So you can use it year-round. It's safe, very, very few side effects, no drug interactions, very easy to use. A little bit of an expense when you first get it because it's not covered by Medicare, but it very well should be covered by Medicare because it's such an effective and inexpensive intervention. But it's another great thing to add in terms of the mix of treatments. And the final thing we've got on the list here is behavioral activation. So, one way to think about that is as a subset of psychotherapy, specifically cognitive behavioral therapies. And this can be useful in the context where people have cognitive impairment that may get in the way of their actually doing psychotherapy. So behavioral activation, whole set of skills around that related to scheduling activities and rewarding and reinforcing those activities and so on. So in other words, forms of therapy can be effective even if people have cognitive impairment. And I'll just give you one more specific example. There's a form of therapy called problem-solving therapy, which has been found to be helpful in older adults with depression who have mild cognitive impairment. That's the border zone between dementia and normal memory. So even with some cognitive problems, psychotherapy can still be effective because, again, the great news on psychotherapy is it has no side effects. It doesn't interact with other drugs. You don't need blood work. I mean, it's difficult to get. Access is an issue that a lot of providers that don't take Medicare, for example. But if it's available, it's certainly quite effective treatment. And a lot of times what we're doing is we're combining various modalities to get people better.
Yeah, that's great. I appreciate that. There's lots of different options, and sounds like there's things that lots of people could look into to help with this. So I want to address the suicide piece because I know that's an important issue for you, and you mentioned it early on. That's actually something that's a real concern in the older population, right?
Yeah, I mean it's remarkable because so the news is very different, and what we hear about are kids and adolescents committing suicide, which obviously that is a huge issue, and suicide rates, unfortunately, among kids and adolescents have been going up over the last decade or so. So So that's worrisome. The other major group that's really gotten a lot of news in the last 2 to 3 years are middle-aged folks in their 50s, especially middle-aged white males, and there's a lot of concern about overlap with chronic pain and the opioid epidemic and so on. But if you look at which age group is in fact at the highest risk of suicide, it's older adults. The overall rate of suicide in the U.S. is about 12 people out of every 100,000 every year. So that's the way we can measure it. So you take a population of 100,000 people, wait a year, about 12 are going to die. That's just in general in the United States, die by suicide. For men over 65, that number is closer to 20 to 30, and men over 85, that number is closer to 50. So dramatically higher. So there's also significant age by gender interaction. So at all ages, men are more likely to die by suicide than women are. Men and women both have an increase in their suicide risk in adolescence and early adulthood. Then for women, it peaks in midlife, so about 45 to 50 is the peak incidence of suicide. For men, there's a pretty big peak there. For women, it goes down. It never goes back to zero, but it does go down as women age. But as men age, it just skyrockets, 65 and then on up to 85. So, and there's some interesting characteristics about older adults dying by suicide versus younger adults. So, so younger adults are more like, there are far more attempts, of course, than suicide. But most older adults who attempt suicide die on their first attempt. So it's about 5 out of 6. So there really isn't like a cry for help or suicidal behavior or things like that. It's when older adults attempt suicide, they do it with much greater planning and resolve. And also, there's much less resilience. So an overdose in someone who's 25, they may bounce back from. An overdose in someone who's 85, they could very well die because they're physically not in as good shape. Also, the means of suicide is different. The older you go, the more likely it is you'll use a gun. So, and of course, that's the most lethal means there is. And so for younger men, for men of all ages, it's gun. Gun is number one means of suicide. For women, it's overdose when they're younger, and it's gun when they're older. So 80% of elder male suicides are by gun, and about 40% or so elder female suicides are by gun. So they choose a more lethal means, in other words. So the take home from this is that we have to take suicidal ideation very, very seriously in this population. It's not just normal to think that I should be better off dead just because I'm 85. It's a sign of depression. And the good news is it's actually quite treatable. So when you look at causes of suicide in younger folks, it's complicated. There's depression, there's bipolar, there's anxiety, there's substance use, there's personality disorders, there's eating disorders. When you look at older adults, about 80% or so of elders who have died by suicide were depressed in the period leading up to it. And remember, depression is identifiable and treatable. So that means we could actually probably, if we identified all older adults with depression and treated them appropriately, we could actually knock off the suicide rate by a very significant amount in older adults. So if a patient who's older, really any age, of course, we talk about suicide, we take it seriously, but we especially take it seriously and have a low threshold for aggressive treatments for depression if a person's expressing suicidal ideation.
Wow, that's real sobering information and really good to know because I agree with you. I think we sometimes don't recognize how serious this issue is for older adults. So, Art, that's a lot of great information. I really appreciate you being willing to share this with us. I did have one question for you in regards to the dementia issue. I remember you talking about that sometimes family history can really play into that. Is that a significant predictor, perhaps, of dementia?
Yes. Certainly for Alzheimer's disease, the number one predictor is age, but family history is number two. So parent or sibling with Alzheimer's disease increases your risk. For Parkinson's, I believe there's a bit of a family component, probably not quite as prominent. There's another particularly awful dementia called frontotemporal dementia, which hits younger people 50 to 65 usually, and that has a familial component as well. So yes, is the short answer.
Oh yeah, great. So again, I so appreciate the wealth of information you've given us today, but I do also want to make some time for our participants to ask questions. So operator, if you could help us and let people know how they can put some questions into the queue.
Thank you. We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. We are on standby for questions.
Well, we're waiting for questions that might come through. I know it's a lot of information, and people are probably just trying to figure out sort of where to go with all the different possibilities. I'm wondering if there are some other things, Art, that you think you might want people to take sort of as take-home information from this, or keys that you would want them to remember?
Absolutely. I mean, I just want to amplify an earlier point, and that's the role of alcohol in older adults. So I don't know what it's like in Minnesota and Michigan, but people drink a lot here in Wisconsin, and they don't necessarily reduce that drinking as they get older. So the federal guidelines on this are 7 drinks per week for people over 65 is the max, and I believe it's no more. Actually, John, you know better than I. What are the current guidelines on this?
Yeah, for adults 65 and older, it's no more than 1 drink a day.
Okay.
And so it's kind of 7 a week, right?
Right. So that's
the NIAAA guideline for older adults. So some of the screens don't actually point that out, and it is really important. And it's the biggest shift is for men, because those guidelines are similar for women. But for men, the guidelines are 2 a day or 14 a week. So as a male gets into 65 and up, their previous drinking patterns that used to be within guidelines are suddenly cut in half, and they may not be aware of that.
John, is there a screen that you recommend for alcohol use in older adults?
Yeah, I think one of the things that people use quite a bit has been the Audit questionnaire, and there are a couple of different versions of that. The U.S. Audit is a newer version that has been quantified for the alcohol amounts here in the United States. It's recommended by the CDC, and actually the third question on that particular screener points out the difference between alcohol use in men and women and older adults, and so that's included in the screen. So the Audit is in some ways like the PHQ-9, because the first 3 questions get at frequency, amount, and binge use, but the last 7 questions, a lot of those are, as you were noticing in the PHQ-9, from the DSM criteria, and some of the others address the negative consequences that alcohol might be having on people, which is an important criteria. So that's probably one of the most common and popular screens that's being used is the Audit.
So I can't emphasize enough how important that is to pick up. I mean, I had a number of times earlier on in my career where I just completely missed the person who was drinking significant amounts of alcohol, and that's why they were depressed and why my treatments weren't getting them better. And in fact, I've now incorporated a routine screening using the Audit for all my older adult new patients for that reason. And so alcohol is problematic for older adults for a lot of reasons. It's neurotoxic. It kills brain cells. When you're older, you're already losing brain cells. In fact, your peak brain volume is at age 25, so you're net losing brain cells after age 25. So alcohol accelerates that process. And it particularly affects memory and affects mood and affects balance as well. And those are, three big geriatric things: depression, memory loss, and falls. So they also can interfere with the effectiveness of antidepressants. So I usually counsel people, if they're depressed and seeking treatment for that, the best bet for them is to cut out the alcohol entirely until we get the depression under control, get the treatment figured out, and then, if they want to resume drinking after that, then, they can sort of gingerly, carefully reintroduce alcohol. But while we're trying to get them better, we really do try to get alcohol out of the picture.
Yeah. I understand we have a couple of questions in the queue. Operator, can you help us with that?
Yes. Our first question comes from Olivia Tice.
Yes, in the end-of-life world, I'm just wondering where, for example, under hospice care, an individual has perhaps at their disposal immediate intensity of narcotics. And if you have any thoughts around where depression could or couldn't play a role in abuse of those medications at that time.
Oh, thank you for that. Great question. Yeah, end of life gets complicated because, things like suicidal ideation and thinking about death and wanting to die and all that all gets a lot more complicated than what I presented earlier. And I think it's really hard to sort out. So so trying to figure out, are they in fact depressed, and that is what's leading to suicidal thinking, which in turn then could lead to perhaps misuse of opioids, either for attempted relief of the depression or using excessively with a goal of self-harm, versus the person's at the end of their life and they've made a rational decision. I really don't see much point in going on here. This may be my bias because I'm a psychiatrist rather than a hospice palliative care person, but I tend to sort of think it's depression until proved otherwise. And if a person is feeling sort of guilty, worthless, helpless, so the other classic depression things, that's probably depression. And so then in that case, we would aggressively treat it as depression, and at the same time kind of really carefully look at what medications they have available to them and minimize any risk of self-harm or other safety problems. But it's complicated. I very much value my colleagues over in palliative care, including psychiatrists who have to wrestle with this on a regular basis, trying to figure out how much of this is depression versus kind of what you'd expect when someone is in an end stage of life.
Thanks. We have a couple other questions, operator.
Our next question comes from Ann Schwartzwell. Your line is open.
Hi, I'm a geriatric pharmacist consultant, so I'm dealing with issues all the time. I'm just wondering if you can touch on nutrition related to depression, since depression is often associated with decreased appetite, and whether you recommend supplementation regarding B vitamins, vitamin D, do you do screenings, do you delve down that path?
That's a wonderful question. Yes, is the short answer. So the most common nutritional deficiency in this setting that's going to potentially contribute to depression or cognitive impairment for that matter is vitamin B12 deficiency. So as adults age, their ability to absorb vitamin B12 from their gut goes down. So the diet may not be any different, but their ability to actually get B12 into their system decreases. So I would say that one of the more common screening tests, lab screenings that I would do is for vitamin B12. The two big ones I would think of are TSH, or a thyroid stimulating hormone, to make sure someone hasn't developed hypothyroidism, and then vitamin B12 would be the other one. So if their B12 is low or kind of borderline low, then I would supplement. And usually we start with oral supplementation. And if that doesn't work, then they may have to switch to once a month intramuscular injections of vitamin B12. For someone whose B12 is normal, there's no evidence that further supplementation is of any benefit in depression. And that's really true of the other B vitamins in general. There is some literature on L-methylfolate, so a variant of folic acid, potentially being helpful in depression, even if people's B12 and folate normals are level. So or are normal. There's a little bit of evidence for that, but it's not a normal part of my practice to do that. Vitamin D is an interesting one. So again, at our latitude, a lot of people, like right now, January in the Northlands, if you went around checking vitamin D levels, they're going to be low in a lot of people. Does that really have a bearing on mood and cognition? Not really clear. I mean, certainly for bone health. If your vitamin D is low, then you're at risk for osteopenia and osteoporosis, and so that's a problem. For mood, not so clear. So I've gone back and forth on whether checking vitamin Ds really makes much sense. I don't do a lot of vitamin D checking myself, but it would be reasonable to check. But if it's low, the reason to treat is because of bone health, not so much because of mental health. The broader point you bring up is really important. So, the diets change significantly as people get older, and so they may not be getting what they need out of their diet. And there's some evidence that there are certain diets that might be helpful for brain health, like diets that are low on red meat, on processed food, on fried food, and kind of more Mediterranean-style diets. There's a specific diet now called the MIND diet, M-I-N-D, which combines Mediterranean and the DASH diet, the low-sodium hypertension diet, that might be helpful for memory. Mood, little less clear. The one last thing I'll say on this is omega-3 fatty acids. So in the West, we have a diet that's very skewed away from omega-3 and towards omega-6. There's a little bit of evidence that omega-3 might be helpful for depression, might be helpful for memory. It's been really hard to prove that that's the case. I have prescribed omega-3 periodically. There's no blood level that you check for that. You would just supplement it. But the data is not super strong that is all that helpful.
Thank you.
Art, I have some questions in the Q&A. The first one says, any thoughts on the mini-COG assessment?
The mini-COG is a cognitive screening tool. It is 3-item recall plus drawing a clock. It was developed to be used in primary care settings where people don't have English as their primary language, so you can very broadly use it. So it's a good, quick screener. It wouldn't be for depression, but it would be for dementia screening. So it's faster than the SLUMS or the MOCA or the mini mental status exam. It won't be quite as reliable as any one of those, but yeah, I mean, it's a good, well-validated dementia screener, especially in a primary care setting.
Thanks so much, Art. I think we're running short on time here, so unfortunately it doesn't look like we'll get to all the questions, but I understand that we will keep these questions and get a list of them and get them answered so that we can send them back out to folks. So again, I want to thank you so much, Art, for being on the call today. I think we probably could have even used more time given all the information that you have. But we do appreciate the time you were able to share with us today.
Thank you, John. Thank you, and I appreciate everyone's interest in this topic. And I would just leave you with depression is treatable. I mean, that's the wonderful thing about this terrible illness, that we can identify it, we can treat it, we can improve the quality of life of older adults, and make sure that they're getting enjoyment out of life in their last 2 years.
Yeah, thanks so much. So I just want to encourage everybody to complete the evaluation at the end of our session today, and I really want to thank everybody for attending. I hope it was helpful for you. Remember, the recording will be available to you on the LSQIN website in a couple of weeks. I know there might be a lot of people very interested in reviewing this information. So once again, thanks Art, thanks everybody, all our participants for coming today. We hope you have a great day and have enjoyed the presentation.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.